Welcome, ladies and gentlemen, and we will call to order our Health Subcommittee of the extraordinary session. It is Tuesday, August 22nd of the year 2023 at 1 p.m. Ms. Adams, if you could please call the roll.
Representatives Hicks. Here. Jernigan. Leatherwood. Here. Martin. Here. Mitchell. Here. Sherrill. Here. Terry. Here. Williams. Here. Chairman Hawk.
I'm here.
You have a quorum.
Chair detects a quorum. Do any of our members have any personal orders before we begin? Seeing none, we have a calendar before us today, and Leader Lambert has to be at another location at this very moment as well. We are going to jump to item number 2 on our calendar to begin. The issue is House Bill 7004. We have a motion. We have a second. Leader Lambert, you're recognized.
Thank you, Mr. Chairman, members of the committee. This comes directly from my sheriff and their experience through transportation of mental health patients, and literally just says that if a member of law enforcement transports someone for inpatient mental health evaluation or treatment, then that transport agency is notified when the person is released. Not diagnosis, not anything additional about them, but just this person is no longer at the facility.
Any questions of the sponsor? Chairman Terry, you're recognized.
Thank you. And so if they've, like under the emergency detainment and where they've got the first CON and they've gone to the hospital, is at what point do they have to tell the agency that they've been discharged? Is it before when you get admitted, you have to have a second CON. So what if they don't get a second CON and they're discharged? Would they have to report at that point as well?
Leader Lambert.
At whatever point they are discharged. So at one juncture, it says if the court releases, another, it's the facility, just whenever they're discharged back.
And from a HIPAA standpoint, are there any issues from a HIPAA standpoint with this?
Leader Lambert.
No, sir, not to my knowledge at all. Again, it is the mere presence or release of that person, no additional healthcare information whatsoever.
Thank you.
Thank you, Chairman Terry. Any further questions or comments for the bill sponsor? Seeing none, are you ready to vote? All those in favor of sending House Bill 7004 to full health committee, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Mr. Chairman and members of the committee.
Thank you. We will now go back to item number 1 on our calendar. House Bill 7036, prime sponsored by Speaker Sexton, is going to be carried by Chairman Dr. Kumar. We have a motion? We have a second. Dr. Kumar, you are recognized.
Thank you, Mr. Chairman. House Bill 7036 is meant to expand law enforcement and mental health abilities to protect the community and the individual with serious mental illness or distress. Currently, a person who is an immediate threat to society or to themselves can be legally detained and presented for mental health evaluation. This bill changes the word immediate to imminent to expand the ability of our first responders and people on the front lines to care for these people and get them the mental health evaluation and help that they need.
Thank you for that brief explanation. Questions or comments for the sponsor? Chairman Terry, you're recognized.
Thank you. And this may be a question for legal, but to clarify, currently law says immediate threat, and we're substituting imminent. I'm assuming, and that may be for legal to answer, that when you say imminent, that also includes immediate. That's what I need.
Okay, and for those, just to verbalize that, we did get a nod of the head that yes, affirmative to your answer, Chairman Terry. Dr. Kumar, would you like to respond to that as well?
It was also a matter of semantics, and immediate threat means occurring at that instant, and imminent means is something that is about to happen. With that, I'll be happy to answer any questions.
Thank you very much. Further questions or comments? All right, thank you very much. Are you ready to vote? All those in favor of sending House Bill 7036 to full Health Committee, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill moves forward, Dr. Kumar.
Thank you, Mr. Chairman and committee.
Thank you very much. We will now go to item number 3 on our calendar. Item number 3 is House Bill 7008 by Chairman Zachary. We have a motion. We have a second. Chairman Zachary, you are recognized to explain your bill, sir.
Thank you, Mr. Chairman and committee. Members, the legislation, the foundation of the legislation that you see before you today is a result of meeting I had with Covenant parents. So I met with Covenant parents sometime during the summer. And one of the issues they brought to me that they felt like was a significant concern was in section of code 33-3206. Many of you will know that is duty to warn or duty to report. As that statute stands today, it only requires a mental health professional to report a specific and actual threat of bodily harm to a clearly identified victim. And so as law enforcement explained to me, if I'm meeting with a counselor and I make a specific threat with a specific name or person, that falls under clearly identified threat. But currently, as it stands today, a mental health professional is not required to report a general threat, meaning if I say in the next 2 weeks, I'm going to shoot up a theater, or in the next 2 weeks, I may go after somebody that lives in Knox County. And so what was brought to me by Covenant parents, one attorney in particular, is that we needed to look at that statute, and based on where we stand in 2023, based on the mental health crisis that we see as our state, as many of you were in the room with me a couple of months ago, the Department of Mental Health told us right before the pandemic, 18% of Tennesseans were in mental health crisis. As of today, that number has jumped to 30%. So we have a significant mental health crisis in our state, and it requires us to look at things just a little bit differently. So what we've done, again, the language that was provided by Covenant parents to us kind of worked. We started that was our baseline to work from over the last couple of months. And so what we've done in this language is take the current statute that you see and expand it on that to include any threat made into a mental health practitioner, any threat of bodily harm against a group of people, but not limited to students, students in a school, daycare, place of worship, or members of a family. So now it expands that. And then if you look in section 2 of the bill, the mental health professional uses their reasonable skill, knowledge, and care ordinarily possessed and exercised by their ability and circumstances to make the judgment if that should then be reported. One of the other things within this statute that was not clear is who to report to. Now it does in 207, 208, 209, you do get some clarity there. But the concern was also, who do we report this to? And in talking to mental health professionals across the state, they said so many times that there is a hesitancy to report directly to law enforcement. So within this legislation, we made clear who they're to report to and gave them the option to either report to the Department of Mental Health, who then would take the necessary steps to report to law enforcement, or if they see it as an immediate threat, then they report that directly to law enforcement. And then also we do provide a carrot at the end of this versus carrot stick. We provided a carrot at the end of this for mental health practitioners that if they do report that, then they have civil and criminal immunity from any legal action that may be taken. So with that, Mr. Chairman, again, we don't open any other sections of code. This is only related to 206. This is only related to duty to warn and report, and it just expands that based on the good faith medical judgment of our healthcare professionals, that if they see that as they see an intent or perceived threat, then they report that to the proper authorities or to the Department of Mental Health. So with that, Mr. Chairman, I'll be glad to answer any further questions.
Thank you, Chairman Zachary. Any questions? Representative Chairman Williams, you are recognized.
Thank you, Chairman Hall. Thank you, Chairman Zachary, for this bill. I just had a clarification. Of course, our hearts go out to any family that's having to deal with these challenges, but it looks as if in section 1 that the only reporting necessary in your bill for bodily harm would be if someone is a threat to a group of other people. As you and I know, generally speaking, some people make threats about themselves first before they threaten other groups of people. If a clinician hears that someone is making an individual threat to themselves, because we know that suicide rates are at an all-time high, what happens in that situation? Is that not required to be reported, or is because it looks as if it reads only groups like places of worship, schools, and those kinds of things?
Chairman Zachary.
Thank you, Mr. Chairman. Yes, sir, Chairman Williams. So this does not address the individual. It requires reporting for the group, but it also doesn't limit the reporting for like what you talked about, suicide. So they still, we're in no way limiting what they report currently today. The code is very bare, but it still doesn't limit them from reporting a general threat. So they can report a general threat today. There's just no requirement to. So this particular step we're taking, we're clarifying that more in code, that for if they make threats toward groups, then there is a requirement to report, but it's not limiting that you can't report for like a suicide situation, which you're talking about. Because in talking to mental health professionals, they do that on a daily basis, either through 988 or the Department of Mental Health or whatever that may be.
Thank you, Chairman Williams. Chairman Terry, you're recognized.
Thank you, Chairman, and thank you, Chairman, for bringing this bill. A few comments or questions, and I actually did not file. I had a bill drafted, but didn't file it for the special session, dealing with all medical professionals as far as, and you mentioned the carrot or the stick, and as far as duty to warn and authority to warn. And one of the things that I would say that's lacking is continuing medical education or educating of our providers in how to address these types of situations. Some are specifically trained, but unless you're going back and getting CME for it. So anyway, that's something that I think that if this goes along, even if it doesn't go along, I think that's something that we do need to pass in 2024. That being said, we just passed a bill that moved the term immediate to imminent. And in this bill, you have intent for or perceived actual threat. And to me, that's kind of confusing language. A perceived threat it may not be a real threat. And whether or not, if this goes through, a mandatory language to address that, or to at least put it in sync with the bill that just went through, so we don't have conflicting things within our code. Is that something that you could address?
Chairman Terry. Excuse me, Chairman Zachary.
Thank you, Mr. Chairman. Chairman, yeah, really good points. And so I was going to say this in my closing comments, but I'll say it now. So the Department of Mental Health is going to bring a clarification amendment if this committee chooses to move it forward, that we'll be bringing tomorrow, and we'll strike perceived from this. So that'll be stricken out. And then they're just going to clarify in terms of the reporting. Because right now we've got Department of Mental Health or law enforcement. So there's going to be some clarity brought to those two sections. Yeah, thank you.
Thank you.
President Mitchell, you're recognized.
Yeah, thank you, Mr. Chairman. My concern with, notifying law enforcement, I've seen it here in Nashville, unfortunately, too many times. You said it yourself, about 1 in 3 Tennesseans, you said, are in some type of mental health crisis. Well, law enforcement many times are not equipped to handle a mental health crisis situation. I can still, this brings to mind, a gentleman here in Nashville had a mental health crisis and on the side of the interstate, and the response was more or less a firing squad, and just shot him down in the middle of the interstate. I'm hoping if we're going to start reporting everything that someone deems as a threat, we're going to follow this up, hopefully with the resources to law enforcement, so they can have mental health crisis teams to help their officers respond. Because most law enforcement officers aren't trained to respond to a mental health crisis. So that's my big concern of this. Are we doing something, a step in the right direction? maybe. But there's a whole lot more pieces to this than somebody just picking up the phone and making a phone call. And I hope everyone understands that. Thanks.
Chairman Zachary, your
Thank you,
response.
Mr. Chairman. And to your comment, so I did talk with the Department of Mental Health. And so when law enforcement is engaged, like your roadside situation, that's on a shelf unto itself, because this is when they're meeting with a mental health practitioner, and the mental health practitioner perceives it as a threat based on their training. They perceive it as a threat, and then they go to report that. Right now, the statute doesn't even tell them who to report to, but in 207, 208, 209, 210, it references law enforcement and what's got to be reported. So what we're doing here is adding the component, the mental health component, where even if they just simply call 988. But then what happens in talking to the Department of Mental Health and law enforcement is then supposed to engage the Department of Mental Health, and they do that together. So I spoke with Sheriff Spangler, who's our sheriff in Knox County, and he said their process is when someone were to dial 988, they engage the sheriff's office. They do what's called a wellness check. They go out working in conjunction with the Department of Health and with mental health professionals in Knox County, be Helen Ross McNabb. They then go out, do a wellness check, work together with them to evaluate the person. They're going to somebody's home, and then they determine what the next step is. So part of that is being done today, but this small section of code that we're dealing with doesn't address beyond what's just in here. But to your point, it is something that we're trying to accomplish here by giving them an option. Because again, what I've heard from mental health professionals as we've circulated this bill is the challenge with most mental health professionals is they just don't simply want to engage the criminal justice system and turn somebody over to law enforcement, because they don't fully understand many times what those steps will be in law enforcement. So what we've done here is given them the ability to then engage mental health, Department of Mental Health, and then they evaluate from there, and they determine if they need to take this next step with law enforcement.
Representative Mitchell.
Yeah, thank you, Mr. Chair. But my concern is, too many instances. There was a story just recently. Law enforcement went to a home for a wellness check, and the wellness check, the person hadn't been taking their medicine. So that wellness check turned into a death. The police officers shot the mentally ill person. So, I mean, we gotta understand what we're doing. That's probably part of why mental health professionals are reluctant to call and report things, because, they know what it could lead to. Thanks.
Chairman Terry.
Thank you. And just to follow up on Representative and to y'all's comments, 988, I guess it's professionals deemed by the commissioner, physicians, psychologists, they have, and psychiatrists have the authority to detain somebody if they're mentally ill or have a serious emotional disturbance and have a threat to others. The question then becomes, who do they report that to? And that's what, we're discussing here. And as far as, being a physician, how do you detain somebody as a physician? Who do you call? I mean, you have a psychiatrist that, she may be 120 pounds soaking wet. How's she going to detain a 6'3", 250 pound guy? So there, as the representative said, there are other pieces that we as a General Assembly are going to have to deal with. Crisis intervention training for our police officers right now, as far as that process is going, whether or not we offer that and the state pay for that for a crisis intervention team for every county or something along those lines, where our professionals can contact those trained individuals. Those are things that we as a General Assembly are going to have to put together for these types of situations, so that we don't put our healthcare professionals at risk in these situations. But to your point, this is just one piece of the puzzle. We are going to have to put a lot of pieces together for this, but thank you.
Chairman Williams, you're recognized.
Thank you, Chairman. Chairman, if we don't pass this bill today, what will change?
Chairman Terry.
Zachary.
Chairman Zachary, it's twice. Third time I
That's all
strike
right.
myself
That's
out.
all right.
My apologies, Chairman Zachary.
No, you're good. So Chairman Williams, if we don't pass this bill today, then mental health professionals meeting with those who are a danger to society, who make threats, general threats, will not be required to be reported. Well, I'm not going to say that. Just meeting with Covenant parents, specifically two that I met with, they were really passionate about dealing with core issues that maybe led to this. And one of those, they felt one of those core issues may be a duty to warn or duty to report for general threats. No specific threats were made. And I'll say this with complete confidence. If we pass this legislation, it will save lives. There's no doubt, because every day mental health professionals are counseling those who may make a threat. And again, it's not a specific threat, so they don't have that duty or requirement to report. If we pass this, it raises a new level of awareness and puts a new new section within duty to report. And if it saves one life, man, it is worth us being here for a week in August to pass this legislation.
Chairman Williams.
Thank you, Chairman Hawk. I just wanted you to verbalize that, because I think it's really important. You know, we came here for a purpose. It's an extraordinary purpose, which we came here so that we could impact the way we currently practice medicine in this case, or counseling services, because we heard many examples in here today about where things have gone wrong. But if we don't do what you're proposing doing today, then we'll continue to get the same results that we do going forward. And I think this is our opportunity to try to impact the lives of not just students in this case, but also places of worship and others. And so I applaud you for your work here. I know that you've spent quite a bit of time on it, but I do think future lives will be saved because of this, because of reporting, and those lost by not reporting, as we've seen in the past, we don't ever want to happen again. So thank you. Thank you.
Thank you for your indulgence, Chairman Zachary. I'll
There you
make sure
go.
to get the names correct, and I won't strike myself out. We do have an individual in the audience who would like to speak to this, who has informed us of that fact. Dr. James McKenzie is with us. Dr. McKenzie, if you could please come to one of the chairs at the front of the room. We will go out of session. Dr. McKenzie, if you'll find a seat that has a microphone in front of it and press the button that has a little face on it so we can hear you when you speak. Are you there?
Test.
Okay,
Sounds
you
all
are
right.
there.
All right.
Dr. McKenzie, a typical process, you have 3 minutes, and we will begin the timer whenever you introduce yourself. Tell us who you are and why you're here and what you'd like to know about the bill. You are recognized, sir.
Thank you, Mr. Chairman. Thank you, members of the committee, for letting me talk. My name's James McKenzie. I'm a child psychiatrist here in Nashville. I work at Meharry Medical College, and I'm on the front lines for mental health care, and I do this every day. I do risk assessments every day. I teach medical students how to do this, and I'm here to speak against specifically House Bill 7008. The idea behind it, I support. I want to do more. We need to do more for our mental health care system. It's true. But this bill, as written, would cause immediate harm to the mental health care system. The idea that we could change some of the words, we can bring down the bar, and that maybe somebody could have stepped in earlier in one of these tragedies is admirable. But the idea that we're going to use involuntary commitments, locking people up, taking away their civil rights for a perceived threat, for predicted harm, as written in the bill, is unfortunately, it's a fantasy. And as a psychiatrist, I can't do it, and I wish I could. And we need a lot of things. We need more people working in the system. We need more resources for patients. But doing this to change the language to lower the bar on risk would immediately put more folks into the mental health care system, where we already have a backlog of patients who have been committed but can't be accepted to a hospital. It would immediately cause overburdening on a system that's underwater. And it would cause for us, for workers, confusion to try to figure out how to apply this new standard that's not based on any sort of medical background. It's really a hope. And so I see this as really a new set of problems that's disguised as a solution. And again, the idea behind it that we can do more, I do support and I want to do that. But this bill as written will just cause new problems. And so I'm here today to share that as my experience as a frontline worker and a psychiatrist, and that I ask that we please do not pass this.
Thank you, Dr. McKenzie. And your comments do reflect the piece of legislation that we have before us now. And as was mentioned by the bill sponsor, there are going to be some words that are tweaked a bit. And there will be an amendment that should come forth should this bill pass to full committee tomorrow. So just a heads up that there will be some language that we will look forward to seeing in this legislation should we move forward. Chairman Jernigan, you are recognized for a question of our
Thank you.
presenter.
Thank you, Chairman Hawk. And, so, and maybe kind of following up what he just said, the sponsor said that they do plan to strike out perceived, which I guess leaves predicted. So if perceived is striked out, do you have an issue with predicted? Or, and that's my question. And what would and it could be, when we get back in the session, I asked the chairman what predicted the definition, I guess, for that is, but if perceived is striked out and predict is left in, what are your thoughts on that?
Dr. McKenzie.
Thank you, Representative. So perceived and predicted are the same problem. And I think the general problem with this bill is lowering the standard in hopes that we're going to catch more folks before they commit an act. And so even if we change that word slightly and pick a new word, keeping predicted in, this idea that we're going to anticipate problems before we have evidence of any kind to use this severe intervention is going to be problematic. And so we might find another synonym that's slightly different, but perceived, predicted are both problematic, and they're both going to cause the confusion and the backlog and overburdening of an already under-resourced system.
Chairman Jernigan.
So I think I get what you're saying. So you're saying that maybe even a word predicted or whatever interchangeable word they want to use. Not every doctor is going to use the word or use predicted the same. And some doctors are going to see or look at it, I guess, in a liberal way, or in some in a conservative way, some in a conspiracy way, and some in a very scientific way. So your issue is that the definition is all over the board instead of a direct. Is that correct?
Right. It's
Okay.
creating a new standard, and I realize it seems like a small change, but it's going to have huge impacts on how we practice, and that's one of the unintended consequences is confusion and stress on mental health workers to try to decide how we're supposed to live up to this new law that's not based on our training, that's not used nationally like the current standard is.
Okay. Thank you, Chairman.
Thank you. Chairman Terry.
Thank you. And I just want to get a little bit more clarification, because current law says communication of an actual threat. And the way this is worded says communication, an intent for or perceived actual threat. And if we strike perceived, I don't know the intent of or what may come in as far as an amendment, but if it still says, if it removes perceived and it's communicate intent for an actual threat, that doesn't seem to me like that would change current statute of how that's, would you agree?
Right. So communicating
An
an
actual
intent
threat.
for an actual threat is what we already do. We
Okay.
already communicate that. And there may well be some providers who don't know who to report that to, but we're trained, and we talk about that all day about who you call and how we get folks help. But if we just struck that and said intent for actual threat, it wouldn't be any different than what we've already got.
Okay.
Dr. Terry.
Thank you. So the term, whether we put in the term imminent threat versus immediate threat, does that make any difference to you?
So that's the standard right now. So an imminent threat, and so like
That's going to be, okay.
we talked about, this could be something that we think that they are likely to do in the near future because they've got access, they've expressed it, or because of their history, they may not even say the magic word, so-called. But if we know from family, from other people in their life, or from their past history that they're at an elevated risk, we would hold it to that imminent risk is what we would report and we would intervene in. And so leaving that as the word would not change the law as it is.
Dr. Terry?
All right, thank you. So obviously, we have a shortage of psychiatrists. It's difficult to recruit. Do you perceive anything, if this bill were amended, perceived, taken out, requiring a reporting mechanism? Because like right now, under I think 33-401, you can detain somebody if they have a known mental illness or serious emotional disturbance and have a threat to themselves or others. You can detain them for their first CON to be admitted to the hospital. Under this, if we struck that out and now you have an imminent or known threat, and that's reported, would that be an issue for you guys? And as far as increased risk of, again, 120-pound person, soaking wet, 6'3", patient, is that going to be an increased risk to you guys as providers, or how's that going to impact this?
So you're asking about the reporting part of it?
Yeah, if you're required to report off of this, as opposed to you have under current law, you can report and detain somebody. Is this going to change? Do you think this is going to impair our ability to recruit psychiatrists or any other healthcare providers that take care of these patients?
I think if we were to pass this and create a degree of confusion and create a difference in the way that we're applying that standard than the rest of the country, it's not going to attract any psychiatrists to come to practice in that environment. But I say if we didn't change the wording around the intent level and all we did was clarify the reporting mechanism, it would not change our practice today. We already have an ethical and a medical legal duty to report actual threats. And so clarifying who would be involved, making Department of Mental Health more involved would be different, but it wouldn't change the way we act already.
Thank you.
Thank you. Chairman Williams, you're recognized.
Thank you, Doctor. Thank you for coming. So obviously, this bill emanated from some multiple discussions that the chairman had with the Covenant families. Could you explain to me, as a clinician, an example of where you would report under current statute and where you wouldn't report under current statute?
Sure.
To which entity?
Sure. So, maybe an example of a person who came to my office and I asked them common question about, have you had thoughts of hurting anybody else, hurting yourself? Maybe that person tells me no.
Mhm.
But I've talked to their family. I know this person's medical history. I know that they've done it before. And for example, I know that they own a firearm that's deadly and accessible to them. That potentially, if I hear from their other doctors, their family members, that they're concerned because this person has been saying things, doing things at home where I can't see them, that have those people afraid, I would report. And so that's the county where someone lives, and it's using mobile crisis. We've got, in every county, we've got folks who can go to wherever that person is to do an evaluation and decide if they need to be brought to the hospital for part 2 of that evaluation before the admission. So that's an example of, people say, well, if they just don't tell you the magic word, you can't do anything. You'll be unable to act, and that's not true. So that's an example of when I would act and report immediately, even when that individual told me to my face that they weren't going to do anything because of that extra information. And that's part of our work to do. And another example, talk to kids, talk to adults who are have gone through hard things in life. They've been traumatized. Maybe they're just in a tough place where they are, and they say, you have any of these thoughts to hurt yourself? They say, well, sometimes I wish I just didn't wake up. That's the thing I hear all the time. But that means something. We talk more, and I get more details about, well, what does that mean when you say that? And so if you took that at face value as a perceived threat, somebody who under this wording in the law, I might be required to send for an emergency evaluation. That's something that a lot of people say when they're just sick and tired of their current circumstances. They want help. They want things to get better. But if I know their medical history, their family, I've talked to things, I know that that person may not be at an actual imminent risk. They may just be sick of the things that have been going on recently. So that might be a case of, even though somebody said something that at face value, if you just read the words on it, would be some type of a threat, I know because of the larger context that they're not at an actual threat to hurt themselves. And that might be somebody I didn't report.
Thank you, Chairman. The doctor, if, stated earlier, or you stated earlier, that if this bill were to go in effect, it would have a diabolical consequences as it relates to your
Immediate
practice.
negative effect.
Yeah. And so I guess my question to you is, describe what that looks like. Are we talking about we'll overload the system or the mental health, services system, or there aren't enough clinicians? Tell me why that would be. I guess I'm having a hard time linking the two. If you're saying they're not an imminent threat and you have the ability to determine whether or not they're reportable or not reportable under the current statute. Can you help me with that a little bit?
So why changing the
Yeah,
standard would
what is-
overload the
yeah.
system? Sure. So I'm also a member of the early intervention group for the Community Mental Health Services Initiative, part of the Public Health Department. And so our biggest issue that we've identified for Middle Tennessee is that children are sitting in emergency rooms who have already been deemed necessary for inpatient medical care. So they've been involuntarily committed. Psychiatrists seen them, said, you need to be in the hospital. And we can't get a hospital to accept them. So they sit. There was a kid yesterday I was on a call, just got off 30 days of sitting in an ER without treatment before being accepted. And that's an issue of hospital staffing. It's not that we don't have beds. We do. We just don't have hospitals that can safely take the people already at this moment are sitting in our emergency rooms into care. So it wouldn't address access to firearms. It wouldn't address the workforce. It wouldn't address any of these larger things. All it would do is say, we need to report more people and put them into the system. So it would send a number of people who now meet this new lower bar of risk to be evaluated in emergency rooms. And if they're deemed to need treatment, they would sit on that wait list, and they would add to, that's the already burden thing. And it's really worst in the rural parts of the state where we've got fewer beds. So there's a kid sitting for weeks in an emergency room with 4 beds. 25% of their hospital's emergency suite is holding somebody who's not getting care. And so that's the active problem in Tennessee right now that this would exacerbate immediately.
Final question. Yeah, final question here. I hear what you're saying as it relates to the overburdening the system. I have mental health patients that sit in ERs in my community for days on end, and it's terrible. But on the other hand, it's our duty as legislators to provide the resources in order to meet the needs of our citizens, regardless of what that looks like. And so my question then to you would be, if the resources we were able to find and the beds we were able to open, and we could provide all the services that we need to meet every need based upon this law, you would still not do it. I guess what I'm asking you is, are you telling us we shouldn't make this decision over things we can control and you can't, like funding for services? Or are you saying from a clinician's perspective, we shouldn't do it?
I'm saying as legislators, making this change in the verbiage for this statute would cause unintended negative consequences that are not the goal, I think, behind this, of being able to get more people help and prevent these tragedies. And so
Maybe I'm asking the question incorrectly. So if I won that $1.2 billion Powerball the other day in Florida, and I said, all this money is going to fund, and I'm going to open every necessary bed needed in Tennessee, and I'm going to go and find every clinician I can, and I'm going to bring them to Tennessee so we can meet the needs of the mental health space in our state. All the money aside, all the resources aside, you still wouldn't enact this piece of legislation if you were in our seats.
As written, no. So
Okay.
the second part is the confusion and ambiguity, because it's not clearly defined what these mean, would cause confusion for the workforce. So even if we had a perfect workforce completely supplied, as written, this would cause confusion and problems for all of them. So I would recommend against passing it as written, even if we had a perfect system.
Representative Mitchell.
Yeah, thank you, Mr. Chairman. So I think what you're saying is our current law is probably part of a model statute that is the standard in all 50 states.
Correct.
So we would be the only outlier with a different standard in the entire country. So I think other states have had the same problem and situation that we're currently in, and they've solved their problems other ways than on the backs of the mental health providers.
That's correct.
Okay. All right. Thank you.
Representative Sherrill.
Thank you, Chairman. Just one question. How often do you report someone in this?
Well, let's see. I reported somebody last week. I work in an outpatient system primarily, so most of the patients I'm seeing day to day are doing well, are stable. But we send folks for evaluations. There's always going to be two steps to it. Through my career, hundreds, thousands of times. In the past month, twice.
Twice. Okay. All right. Thank you.
Sure.
Chairman Terry.
Thank you. And getting back to two of our representatives' questions, as far as the word perceived, if that stays in there, would that impact negatively the relationship you potentially have, or psychiatrists have with their patients? Would that make it a medical issue for you?
Right. I think the next step to this, if this was to be passed and this confusion was created around perceived threats, I think it would directly impact the trust that we have with our patients, the patient-doctor relationship, for them to be able to feel like they can tell us about things that are going on in their life. And so I think certainly folks would think twice about being honest with their doctors about what's going on in their life. And maybe those people who are at the highest risk of hurting themselves or hurting somebody else would decide not to say anything to anybody out of fear. So I think that's exactly right. That's one of the other unintended consequences that the language of this bill could have.
Okay, and so if we struck perceived or had imminent or immediate, no real change in how the relationship you have with your patient or with the burdening of the system. Is that correct?
Correct. So if we didn't change any of the wording,
If we took perceived
from the
out?
current, yeah.
Okay. All right. So, and from an overburdened system, I want people to understand this. I believe 988 had, 70,000 calls last year. 28,000 got a first CON to be admitted to the hospital. And I believe there were 16,000 that got a second CON. And of those 16,000, 8,000, I think, got committed. Those are the numbers that I recall. So if we have perceived in there, then that 28,000 may be, astronomical. And one of the reasons, my understanding, why 988 hasn't been rolled out and pushed as much as possible is because there's concern about the capacity that we have right now. And so that's your concern. One of my concerns with having perceived, if all of a sudden now we're got 28,000, those that actually need help, they're not going to have beds. People that are in true emergencies that aren't a true threat aren't going to be able to be there, or those that actually have a true emergency, they're going to be in the hallways of some of these hospitals. And so I just want to point that out from a burden standpoint, that's one of the concerns. And like I said, I do believe there's an amendment that's going to be coming to help with that. So anyway, that was my comment.
Any further questions, comments for the presenter? Thank you very much, Dr. McKenzie.
Thank you.
We will go back into session. Chairman Zachary, we heard a lot over the last few minutes.
Yes, sir.
You're welcome to respond as you need, sir.
Absolutely.
Chairman Zachary, you're recognized.
So thank you, Mr. Chairman. Quite a bit to unpack there. Let me just kind of quickly jump to the facts so that way we're operating from a basis of fact. So currently in the statute today, this is a duty to predict and warn. Currently, mental health professionals are required to report an actual threat. They get to use their reasonable skill, knowledge, and care ordinarily possessed or exercised by their profession. So that stays within the bill. So, Mr. Chairman, it's important that we not talk in practice guidelines and things that are outside the law. Our job as lawmakers, all we have to go on is the law as it's written. So some comments were made about lowering the bar. We're actually raising the bar. We're raising the bar to protect Tennesseans. There is no additional burden on mental health professionals. Again, I have spoken with so many mental health professionals and sent this to 5 different entities, one of the largest in the state that goes from Memphis to Mountain City. Much of the language in here is based on that feedback. And so let me just start first with, there was a comment made about involuntary commitment. This has nothing to do with involuntary commitment. That's not in this statute. This is a duty to warn. Has nothing to do with involuntary commitment. Another comment was made about the same standard being in all 50 states. I just got on ncls.org, and there are 7 different standards: duty to protect and warn, mandatory, permissive. There are some states that don't even have a duty to warn. Georgia in particular is one of the loosest states. I read their statute quickly, where they provide absolute flexibility to the practitioner to report as they wish to report. So there is no standard across all 50 states, just to be clear. There was also much talk about the words predicted, unless I have missed it. The word predicted is not even in this language. Perceived, we've already discussed that, so we're going to pull perceived out. I won't go over the definition of intent. I've got other definitions to find here, but the bottom line is, Mr. Chairman, that currently in the code today, we have a duty to report. There are some that feel if the statute was written as it's written today, the covenant situation could have been different. Again, we don't know that. It's based on opinion and based on those who meeting with covenant parents who have opinions based on talking to law enforcement and putting together the information the best they can.
Yeah.
The doctor talked about certain guidelines and reporting that are within his practice. That's fantastic, and that's great. I'm so glad certain medical practices have significant duty to warn and report, but he talked about family and all these other things. This statute deals with the service recipient, who is the patient, and the medical health practitioner. Again, that is what's in code. That's what we're dealing with. So if a service recipient sitting in a medical practitioner, healthcare practitioner's doctor's office, if they make a specific threat, that has to be reported today. If they do not make a specific threat and is more general, statute does not require them to report that today. So, man, that's awesome that certain clinics have the requirements to report any and everything. Law doesn't require them to do that. We have to deal with the law. So what we're saying in this is that if it is a general threat to a group of people, that is now part of the requirement. That is not a burden. That will actually save lives. Again, if it saves 1, 2, 3 lives, based on passing this legislation, it's worth it. And to the part about staffing, I heard the exact same thing from Covenant to Nova, UT Medical, Helen Ross McNabb, on down the list. We have to fix the funding problem. That is our problem to fix. That's not their burden. That's our burden. We have to pass that. We have a mental health crisis in the state. So part of the push this week, and our hope our friends in the other chamber are listening, part of the thing we need to fix this week is the reimbursements. They're woefully inadequate. He could probably sit back up here and talk to you about the reimbursements, how woefully inadequate they are. They lend itself to significant staffing issues and the inability for our mental health professionals to treat the crisis of their time. So we have a funding problem, but man, that ain't this bill. This bill is duty to report. 2023, when somebody comes in based on 30% of our state mental health crisis, 30% of those people come in front of a mental health practitioner, and I'm so glad the doctor has those requirements in his practice, but it's not in law and they don't have to do it. We're simply saying now you do. It will save lives without question. So again, Mr. Chairman, I would ask for passage on the bill.
Thank you. Chairman Jernigan, you're recognized.
Thank you.
Take a breath.
Very passionate, Chairman, and your own brand there. So really I don't really have a problem other than the word perceived. And so if you're telling me it's going to be striked out and that there's not going to be any kind of interchangeable word with that in the amendment, then I just want to get your thoughts on that, and that should be okay.
No one else is on the list. Are you ready to vote? Chairman
If I
Zachary,
may,
closing
just-
comments.
Thank you. Just if I may, yes, sir. It'll be struck out, nothing replace it. Thank you.
Now we're ready to vote. All those in favor of sending House Bill 7008 to full health committee, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, Mr. Chairman and committee.
Thank you. We're now moving to item number 4 on our calendars. Item number 4 is House Bill 7058 by Leader Cochran. Leader Cochran has asked that this bill be taken off notice without objection. Chairman Todd is the next piece of legislation. He has informed me that he is in Civil Justice Committee at the moment. He does want to present the bill, so we will roll item number 5, House Bill 7025, until Chairman Todd comes into the room. We're now on item number 6 on our calendar, House Bill 7006 by Chairman Subcommittee. Chairman Subcommittee, you all recognized. Do we have a motion? We have a motion. We have a second. You're recognized, Chairman Subcommittee.
Thank you, Mr. Chairman and members. This bill is very simple. It comes from the Department of Mental Health. Commissioner Marie Williams helped me with this language. It does something very simple. It creates a mechanism. For the Department of Health. If the General Assembly or in the governor's budget, he or we appropriate money for mental health to indigent care patients, those that are uninsured in Tennessee, it gives the Department of Mental Health the ability to enter into contracts with private mental health providers and be able to reimburse them for the care of our indigent care in Tennessee. And then the second part of the bill is very simple, it requires the department on or before December 31st of 2024 will submit a report to the Speaker of the Senate and the Speaker of the House on whether an additional inpatient psychiatric services are needed in the city of Knoxville. And that report must include recommendations on whether additional state funds should be expended for the construction of a state-owned and operated inpatient psychiatric facility and hospital. So the first part is a mechanism that if we provide funds for indigent care, they can now contract with private insurers. And the second part is very simply a study to be done in Knoxville to see if we need a mental health facility in Knoxville. Mr. Chairman, I stand ready to answer questions.
Thank you. And I was here when the facility in Knoxville was closed and remembered the pains associated with that and how other organizations and establishments were to take up the slack. And still not sure if that ever happened in the way I would have liked to have seen. Chairman Williams, you're recognized.
Thank you. And along the line of the chairman's thoughts there, I guess the question here is this kind of laying the foundation, the groundwork to be able to reopen a state-owned facility, and that would only be paid for with reimbursement dollars, or would the state be funding the facility based upon its operational costs?
Chairman Spicki.
Chairman Williams, I think that's a question for the Department of Mental Health when they bring that report back to the speakers to determine what their recommendation is and then how they deem it appropriate to pay for it. This is just requiring that they look into a study of whether or not it is a necessity to build a facility in Knoxville and then come back to the speakers to report to them.
Okay.
Chairman Dr. Terry, you're recognized.
Thank you. And can you clarify, did you say that Department of Mental Health and Substance Abuse, they brought you this language or you worked with them? Is this their bill?
You recognize Chairman Sabicki.
Thank you. That's a great question. The original bill I had, Mr. Chairman, that I took to them was a solid no. They did not like the language of that bill at all. It had to do with building 9 mental health facilities across the state. And when I talked with fiscal review on that, the financial cost to the state was going to be very significant. But they came back to me with language on this that you see before you on the need that they had to have to be able to facilitate the indigent care contracts and to start looking at the possibility of building a hospital, a mental health hospital in Knoxville.
Chairman Terry.
All right, thank you. And this is, there was a bill that apparently didn't get filed in the Senate dealing with institution of mental disease and potential issues with funding and a waiver for that. And so I guess my question to you is, since that bill is not going to get passed during this special session and it'll probably have to come up next year, we're potentially going to be 8 months behind on looking at that waiver. If there are threats to our hospitals today, I guess we've got 4 state and 26 others that fall under the IMD potentially. Could some of those funds from mental health and substance abuse that they may have, could they direct it to those facilities or other facilities through a contract if the current ones get dropped from the federal payments? Or is there some way that these funds can be helped in that situation? And in other words, is there a reason for this to pass potentially that we can take care of other patients that it's going to be not there potentially from the federal level?
Chairman Spicky.
I don't want to speak for the Department of Mental Health on that, Mr. Chairman, but I can tell you this. The reason that this bill came about is we have a huge problem in Tennessee with indigent care and those who are uninsured being able to get mental health. Our rural hospitals, especially where I'm from down in Murray County, we take people in who don't have insurance, and it is a huge drain on the financial system and the system in general for mental health and getting people to help. So this gives the Department of Mental Health the flexibility, and maybe this might answer your question, it gives them the flexibility to contract with private insurers or private providers to be able to get reimbursed for helping on indigent care.
Chairman Terry.
Do you happen to know, it says may direct available state funds, the amount of available state funds that might be there?
Chairman Spicky.
So that's a twofold question, or twofold answer right there. The first one is, if the General Assembly deems to appropriate money for this use, it gives them the mechanism to receive that money and use it. There's also on the executive branch, if the governor appropriates money for this in his budget or through a budget amendment, then it gives them the ability to trigger mechanism to be able to do this. They don't have the trigger mechanism to do this right now, so they're stuck. So they're asking the General Assembly to pass this bill so it creates the process that if the General Assembly or the governor appropriates money for this particular need, they have the mechanism to be able to do it and stay within state law.
Chairman Terry.
Thank you. So I guess the question is, today, are there funds that the department, they're shaking the head no, there are not funds. But if we pass this and we have an appropriation bill within our special session, if we put funds towards that, we could have a safeguard in the event that is correct. Okay, I'm getting a yes.
Shaking of the head is yes.
Okay, thank you.
Further questions, comments? I'm wondering if the all right, any further questions or comments? Any closing comments, Chairman Sapicki?
No, sir.
All right, are you ready to vote? All those in favor of sending House Bill 7006 to full Health Committee, please signify by saying aye. Any opposed, please say no. The ayes have it, your bill moves forward.
Thank you, Mr.
Thank you. We're now on item number 7 on our calendars. House Bill 7066 by Chairman Jernigan. You're recognized, sir.
Chairman, I'm sorry I didn't get with your office earlier. I would like to take items number 7 and 8 off notice, please.
Without objection, item number 7, House Bill 7066 by Chairman Jernigan is off notice. Item number 8 on our calendar, as you just heard, House Bill 7067 by Chairman Jernigan requested to be taken off notice without objection. We are now on item number 9 on our calendar. We have a motion. And we have a second. It is by Representative Sparks. You are recognized on House Bill 7052. You recognize, sir?
Thank you, Chairman. Thank you, committee. As other bills have been mentioned, we've got a mental health crisis. I think this is a great piece of legislation that can help relieve some of the overburdens of our emergency room departments. This bill simply requires psychiatric hospitals to update the Tennessee Department of Health's healthcare reporting system, often referred to as a HERTS system, no less than one time per day. I think it's a simple bill. I spoke to the governor a few weeks ago, like many of us have, and I thought this was one of the best bills that could be presented, just to be honest with you. And I can tell you why. A few months ago, Secretary of State Trey Hargett and I were at, we toured my community, and I really appreciate the Secretary coming in. We toured Stonecrest Medical Center, Stonecrest Hospital, that my father passed away in, that my mother was in, that my son has been in, that my sister has been in. And while I was in there, the CEO told us, he says, Mike, we added on all these ER beds, 16 of them, and they're all full. All of them are full, and they're all mental health related. Then he goes on to tell me about another scenario, which I don't want to share on camera, but it showed the seriousness of it. And I was telling the governor, I said, Governor, Secretary of State Trey Hargett witnessed what he said. And I could see the look in his eyes where he was wanting relief. He said, we need to do something. All this is a simple update portal, the HERTS system, to let folks know where there's openings. It takes 2 minutes for them to update this. We all know our ERs are overburdened. Every one of y'all have mentioned it earlier, and I do think this is a good bill that offers some relief. So I ask for your consideration and passage of this.
Thank you, Representative Sparks. We had discussed this bill back in the regular session, and we're having some ongoing conversations between interested parties. Have you been a part of those conversations
have.
this summer?
And looking forward to more conversation, whether it's today, tomorrow, or January. I just don't think, Chairman, that we can wait till January.
Questions of the sponsor? We do have a couple of names. We'll be going out of session in a few moments. We've got a couple of names of folks who want to speak. Any questions for the sponsor at the moment? Okay. We're going to go out of session at the moment, and we will hear from Mr. Elliot Pensley, excuse me, Elliot. Mr. Elliot Pensley. If you could introduce yourself to us once again, tell us who you are, who you're with, and what you'd like us to know about the legislation. You'll have 3 minutes.
Thank you, Chairman and Committee. Thank you, Representative Sparks. This is an issue, we have been talking about this. This is certainly a very important issue. I've heard at least twice, just sitting and observing today's subcommittee proceedings about the fact that we have an emergency department boarding issue of patients who need mental health care but are waiting for a bed to open up. I forgot to introduce myself. I'm Elliot Pensley. I'm the Chief Executive Officer of the Behavioral Health Foundation here in Nashville. We're a nonprofit policy research center. I also am the co-chair of the Tennessee Diversion Coalition, which is a group that works with partners from all over the state and has been since 2016 to work on pre-arrest diversion and related issues with mental health and addiction issues. This idea for a piece of legislation came out of a committee that was part of that coalition, an emergency departments and EMS committee, that we found that there were a lot of folks who had patients and people in their areas that were waiting for psychiatric hospital beds because they couldn't find an opening, and that there's just not a process for that. There's a system that exists, though. It's there. It's been in place since 2006 for emergency departments to use to put the number of available beds they have. So if we have a mass shooting or a tornado or whatever it may be, we got to know where we can take those patients who need urgent trauma care. And that's what this system was set up for. But in 2018, there was a movement to add psychiatric hospitals to this because they also wanted to be able to make sure we can get folks into the appropriate mental health care as quickly quickly as possible. So a lot of psychiatric hospitals have been working in that direction. I know the state regional mental health institutes are reporting into that system at least twice a day. They've added a referral tool, the patient bed matching system that allows folks to make secure communications and referrals into these psychiatric hospitals through the system. And I know that folks across the state have been asked to report into this at least once a day, but not all are doing it. And it's really difficult. There are some hospitals reporting or taking referrals in a separate system, that is a pay-to-play type system, and that's certainly okay. It's just difficult when we're not all using the same centralized system, so that we can see how can we avoid these emergency department situations. I know earlier this year, this committee passed a piece of legislation that allows psychiatrists to, go ahead and file a certificate of need, and then someone can go directly to a psychiatric hospital. But how do we know how to get someone into that hospital if we don't know where the available beds might be? So this is, as Representative Sparks said, takes 2 minutes. It's really straightforward. And the Department of Mental Health has already stated in a report, hospital systems that use the bed registry saw a reduction in their emergency department boarding times. We know emergency department boarding of mental health patients have gone up. The time's gone up. It's about a day and a half or so is on the average that's being reported. But we hear folks all the time waiting for days or sometimes weeks. And this seems to be a bigger issue for children and the uninsured. So this seems to be a very simple measure, especially given how many folks need mental health care, to help reduce unnecessary burden on emergency departments, reduce unnecessary trauma on those we're trying to get into help, and just get them into care as quickly as possible.
Thank you, Mr. Pinsley, very much. That's your 3 minutes. Any questions for the presenter? Dr. Terry, you're recognized.
Thank you. And the current posture of the bill as it's presented versus a bill that we had that passed through this committee, but then got to full committee and has been rolled to 2024. What's different in those two pieces of legislation, and looks like an enacting date and things like that are a little bit different? Can you explain that, please?
Yes, sir. I'm happy to. So there are a couple things that are different. You are correct that yes, the date. So the enacting date is the same. It was always going to take effect immediately, but there is the date at which at least once a day reporting would be required to start happening. That instead of being January 1st, 2025, it is January 1st, 2024. Hence bringing it in special session. That's why that date is there, to make sure that there would be a few months for everybody to get up to speed who may not be in that system. Again, most psych hospitals are using it, but not all of them are. The other changes involve the word currently was added. If you look in section 1A, 1, 2, and 4, before where it says number of currently available staff psychiatric beds, just to add some clarification as to this being a point in time snapshot. Also, there was a change made regarding section 1(6). Regarding the definition for the psychiatric bed tracking system. There was a little confusion last time because this is a system that already exists. It has been in place since 2006. And the previous language talked about establishing a system. So there was just some work, I believe, with legal to resolve some of those issues. And then additionally, there was it would be in section 1B1, there is new. Let's see. 1 is the same, but the 2 right after, it says subdivision B1 does not prohibit a hospital in this state from updating the psychiatric bed tracking system more than 1 time per day. There was some confusion around that and some testimony on, 1 time a day isn't sufficient. We wanted to be very, very clear on this, that this is not about just once a day. Psychiatric hospitals absolutely can report as often as they would like to into the system.
Chairman Terry?
Thank you. And I think there was some confusion of like 2 competing systems. Is this one particular system?
Yes, sir. So that is a very important question. I appreciate you asking. There is the healthcare resource tracking system. That is at its core the system that has the bed availability reporting. And what is being asked in this legislation is to simply report up at least once a day the number of currently staffed and available beds based on the type of unit, geriatric, adult, or adolescent. The patient bed matching system is part of the HERT system. It was an enhancement that was added by the Department of Mental Health in collaboration with the Department of Health. My understanding is that was added last year in 2022, and that is that secure communication and referral platform. And the data that is updated in the Hertz system on a number of available beds directly links with that patient bed matching system. So you're not only looking for a facility that might be able to take care of your patient's needs, but if folks are updating this data regularly, you can see which hospitals are expected to have availability.
All right, any further questions or comments for Mr. Pensley? Thank you very much, sir. We have also wanting to speak on the legislation, Mr. Jim Schmidt. Mr. Schmidt, if you could please come up, and as you've seen previous presenters do so, if you could find the on button, tell us who you are, who you're with, and what you'd like us to know about the legislation. You have 3 minutes. You're recognized, Mr. Schmidt.
Great. Thank you, Mr. Chairman, members of the committee. I'm Jim Schmidt, Schmidt Government Solutions. I represent UHS, which has a couple of large psychiatric freestanding hospitals in the state. As Elliot mentioned and Representative Sparks did as well, you know there was a bill last session. In the end, y'all decided and asked us all to come together and start working on a potential solution. We did meet. We've met once so far, July 21st. We were very appreciative of Senator Reeves and Representative Sparks for pulling us all together. We had a good conversation, I believe, and was a good starting conversation. There are a number of, I won't say it's concerns because I think we all share the same goal in the end is making sure people get into appropriate placements and appropriate admissions at the psych hospitals when they need care. There are the mechanism that's under this bill, which is similar to what was during the session, we don't think is potentially a solution. There are hospitals, like has been mentioned, there are different systems that they use for admissions. This would mandate we all basically input a number once or more a day about the number of available beds. But it's a question of also, is it an appropriate placement? Is it the right thing for the patient? And we don't necessarily think this is the way to do it. I would request, and I think the hospitals would request, additional time to continue those conversations. We think there's potentially other technology solutions that could be looked at, which we think will help actually move people into the admissions and into the facilities quicker than maybe what's been suggested so far. And, I think plans are to get together back next month. Obviously, the special session happening in the middle of this, I think, threw us off for a month, but I think we'll be coming back together next month and hopefully be able to all come back together during the regular session and have something that we think everybody will agree to.
Thank you. Any questions? Dr. Terry, you're recognized.
Thank you. And so to clarify, you guys have met and you met with the sponsor and the senator. And the full committee rolled this issue to next year. Is it your belief or your thoughts that, one, that this bill does not fix the issue, but second part of that is that there will be something that will be available to fix the issue that the full committee can hear next year?
I think that, Mr. Chairman, I think the thought of the initial conversation is really about getting the information to make sure the patient gets to the right placement and they get admitted to the facility quickly. Entering a number of beds in a system a day, we don't think necessarily gets us to the point where that's going to occur quickly. So I think there are other systems out there that different hospitals use that they feel more comfortable and that will actually move the admission process faster. So I think it's still a discussion to be had, and that we need to, continue to explore that. So I hope I answered your question, Mr. Chairman.
But I guess my question is, scale of 1 to 10, how optimistic are you that there's going to be a piece of legislation that all parties can get around that our committee can hear next spring?
I think there's good potential for us to get there. I don't know if I have a number range. I'd probably say more than 50% because obviously it's an important issue, and I think we want to get to that place, and I think that's the hope. So if I got to throw one, I guess maybe a 7, 8, maybe more.
All right, thank you.
To that point, I'm typically of the mind that if we can do something without a piece of legislation, I would rather do that. Anytime you've got words drawn up in the little green books over there, I I'm nervous about what can be said or done in there. And if we can come together as an industry with interested parties to have a memorandum of understanding that this is a way to notify the public or other facilities that these are the beds available, I would love to see that absent a piece of legislation, truthfully. And that's philosophy of mine. So I would like to go down that road as well. Further questions or comments? Mr. Smith, thank you very much. We are back in session, and understanding that we have rolled conceptually the issues of this bill in the full committee. I'm a little bit at a conundrum where to go from here. Representative Sparks, would you like to make some comments?
You can just pass it. You can just pass it. Okay. The full committee
Chairman Terry, you're
for
recognized.
more discussion.
Thank you. And as chairman of full committee and as that committee voted to roll this issue to next year, I want to make a motion that we roll this bill to first calendar of next year.
We have a motion. We have a motion to do so. Do we have a second?
Point of order.
Chairman Jernigan, you're recognized.
Can we roll a bill from one session to another session? We're in special session. Do we have the authority to do that since we're sovereign and separate from the other session?
We have the ability to move any piece of legislation that's considered in this special session wherever we like. The bill doesn't have to be considered or very unlikely to be considered. Okay. Chairman Terry, you're recognized.
I'll withdraw my motion.
Okay, there's a withdrawal. Representative Sparks, you're recognized.
Yeah, you know, this is such a serious topic, members. We all know it's serious. I've seen it personally in my community. We've all seen it. We all want to offer some relief, and we need the discussion. You know, I've often said I've never seen the brokenness in government like I've seen today. It's just plumb broken. Ryan Williams would never run his business the way government's run, or Tim Hicks would. I see a lot of
Chairman
silos
Sparks, I
where
will
people aren't
remind you,
communicating.
we've been encouraged by the new rules not to mention folks' names. And I appreciate it.
sorry.
And I know your style in the past has
I'm
been to
sorry.
do that, but we've been asked and encouraged
I'm
to
sorry.
not name names. So
Well,
Representative Sparks, you're recognized.
Well, I see a lot of silos where people aren't communicating. And the way to get things done is to communicate. If we can move forward with this for full discussion, like we did last year, for more discussion, but I want to remind the members, 20 other states have implemented this. Alabama, Alaska, Connecticut, Florida, Georgia, Idaho, Indiana, Iowa, Kansas, Maryland, Massachusetts, Minnesota, Mississippi, Missouri, Nevada, New Jersey, New York, North Carolina, Ohio, Oklahoma, Rhode Island, Utah, Vermont, Virginia, West Virginia, and Wisconsin. And Chairman, with all due respect, I'd like to add Tennessee to this list because we've got a crisis on our hands. Appreciate y'all's indulgence, sir.
Thank you. Chairman Terry, you're recognized.
And thank you to the sponsor for bringing the legislation. And again, as chairman of the full committee and having heard the will of the full committee on this and having that not have played out yet, however this committee votes, I'll be voting no on this piece of legislation because I do expect that the bill is going to be heard, that you guys are going to sit down, whether this goes through or not, or whether the Senate passes it or not. I do expect that, something's going to be done next year. So I appreciate that. Thank you.
And if I could, I will share the full committee chairman's sentiment. I'm, again, being a private sector individual who wants to see this corrected through these discussions we're having. I cannot support the legislation either, but thank you very much, Representative Sparks. Are you ready to vote? All those in favor of sending House Bill 7052 to full committee, please signify by saying aye. Aye. Any of those opposed, please say no. No. The noes have it.
Thank you, Chairman. Thank you, Committee.
Thank you. We are now on to item number 10 on the calendars, House Bill 7016. Representative Hemmer, you have a motion, you have a second. You're recognized, sir.
Mental health services and resources. This resolution came about, had two significant things that happened to me occurred this summer. First is I had the opportunity to meet with a friend of mine who is a national Medicaid consultant, and I asked him simply kind of what should we be doing more in Tennessee that we're not doing now? And he described in detail a number of school-based services that felt like TennCare, Tennessee was kind of on the back end of compared to our other peer states. The second thing was in preparation for special session, I had a phone call with the Department of Health and Human Services and went over a number of things that basically new grant programs that are rolling out this year, along with stuff that came from the just basically new federal programs over the last few years. And so it also coordinated with a letter that the Secretaries of Education and Secretary of HHS sent to all governors this summer that went through a number of these federal grant programs that were new, that were around mental health, around school-based services. And so in coordination, brought this up to the governor's office, to those two departments, Department of Education and TennCare, and was able to get them to defer on this legislation. Felt like this was just something that was worth looking into. Particularly, one passion of mine was and found out about how some of these programs, and there are exactly 21 other states that have funded these federal programs around school-based services to get mental health counselors within schools. So I think this is just something urging them to look into these programs so that we can do what we need to do for the community and mental health needs for our kids. Thank you.
Thank you. Chairman Williams, you're recognized.
Thank you, Representative Hemmer. Just a clarification. So the reason for your resolution is to encourage the TennCare and Department of Education to do this. You said that they deferred on it. Well, the reason for the resolution is because you don't believe they will?
I can't speak for the departments. I'll just say that, felt like these were a lot of new programs. Again, from my research, it felt like there was some things that TennCare was falling behind on compared to other states. And so being that these were new programs, this was something important enough for the Department of Education and Department of HHS's secretaries to send letters to all governors about this summer. Felt like it was worth the position statement to urge that they look into this in a serious nature and apply for anything that is worthy of application here in Tennessee.
Chairman Williams.
Thank you. And so when you discussed this with TennCare and Department of Education, were they aware of these programs?
I can't speak for everyone, but and for all, there's probably about, it's a 4-page letter. I'm happy to provide it for you afterwards. There's probably about 10 different grants, so I can't speak for all of them. I know, again, my main interest is around these school-based mental health counselors, and this was something that was of new nature to them, but they've ultimately deferred on the resolution.
Chairman Williams.
The reason, I'm not trying to be difficult, the reason why we normally do resolutions is because we want somebody to do something that they're unwilling to do. And if they deferred on this, maybe they were they weren't willing to do it. I just thought it would be important that you would go on the record if you're going to go, because a bill would require them to do it. This would strenuously suggest that they do it, but usually we only do either one of those things when they're not willing to do what it is we ask them to do. They've been pretty amenable to me over the years, I guess, both the departments, and I just wondered if when you asked them to ask for this money, whether they were unwilling to do that. But that would be a good reason to have a resolution.
You're recognized.
Thank you, Mr. Chairman. I'll just say my conversation with just today, even with the Department of Education, there's liaisons who spoke with the COO, handles the grants. They're very willing to work through this. So I'll also say that earlier in the summer when I came out with this, I brought this up to the governor's office and members of the committees that were looking at different things and wanted this to be part of kind of a broader package and have some broader commitments. And wasn't necessarily able to secure those. So I felt like it was important just to bring this up because it did fit within the call. And it is such an important and timely topic.
Thank you.
Chairman Jernigan.
Thank you. We, since I've been here in the House Joint Resolutions, we've done a lot of different topics and a lot of different issues. But specifically, joint resolutions is that this body resolves that we're interested in something and that we want to weigh in and say, these are our thoughts and these are ideas and our feelings on a matter. And in this case, we're just sending a message that the General Assembly is interested in you applying for grants. Whether they are doing it, then great. We're backing them up and encouraging them and we're with you. And if they're not, then they should. So I don't see the harm in the HJR. So I'm going to support it and thank you for bringing it.
Chairman Terry.
Thank you. And thank you for bringing the resolution. I'm trying to wrap my head around the, because you said it, I guess this says urges to coordinate and apply, and you said to look into, which is two different things. And it's one of the things from our committee, we don't know what all, if they're going to apply for certain programs, what strings are attached to those. Those aren't things that has been brought to our attention, urging them to look into, or, that's great. I would love for them to look into it. The question is, what are they applying for and what strings are attached to that we simply don't know about? And that's a concern that I have as this is drafted. As chairman of health, I can write a letter directly to the departments and say, can you provide me information on this, have it to our committee by January of next year so that we know what we're actually urging them to apply for. Is that something, from a process, how we're going to do this, is that something that had you thought of or how this is going to work?
Representative Hibber.
Thank you, Mr. Chairman. Yeah, and that's exactly why I wanted to do an urging versus a requirement, a shall requirement, in that, there may be something that it may not meet our specific policy goals. And the fact that there was, as I mentioned, I don't have the exact number, but it looks around like 10 plus different grant programs that were mentioned. So I wanted to give some flexibility to the departments who ultimately do make these policies. But in general, though, there are a number of good things like the school-based counselors that we're not, quite frankly, more toward the minority of states that are not taking advantage of these. So this was a number of things that were brought up to me by senior HHS officials and felt like it was worthy of us exploring further. And so that was the intent of my legislation.
Chairman Terry.
Thank you. I still have a question about the coordinating and applying for grants. Maybe it's semantics, maybe it can fix in an amendment, maybe I don't know.
Yeah.
But whether this goes forward or not, the process I think is getting that information to us as a committee. And so depending on how we vote on this, I will be sending a letter out, because I do appreciate you bringing this, because that's something I think that as a committee we need to know the details of what these programs are and what they could apply for, what strings are attached to them. But I just have concerns of urging them to apply for something that we just don't know what we're urging them to apply for. So,
Thank you. Representative Hibber, did you have a response?
Thank you. And if the committee so chooses, I'm happy to forward along the letter that has a lot of the details of the different grants that was submitted in June 15th from the Department of Education, Department of HHS, so that you could look at that. And again, I do feel like that, coming from an administration official, there are thousands of these grant programs and opportunities that come about a lot, and so some things work for us, some things don't. So I want to give the people whose day job this is to have that flexibility. But the fact that there were some that were clearly that Tennessee should look at, and then also a bunch of new stuff. Again, that was the real intent of the legislation, was just to make sure we were urging. So if I said something wrong in my presentation, I would go back to the resolution, which is urging both departments of TennCare and education to apply for these grants if deemed necessary.
Representative Mitchell.
Yeah, thank you, Mr. Chair. Representative Hammer, I think you said it was school mental health counselors was the one grant in particular you were looking at. Is that correct?
Forgive me, Representative Hammer, you're recognized.
Thank you. Trying to be good here. Thank you, Representative.
It's like, is that a tough one?
That is correct. That is one of the items that is mentioned specifically in there is for school district to train school-based mental health professionals. And there's also 2 existing other programs that are happening today: the elementary school and emergency relief and state and local fiscal recovery funds may also be used to support those efforts. So again, it's just a number of existing, but also new federal funds that are available to support these school mental health professionals. That was why I brought this legislation.
Well, I appreciate it. You know, I'm sorry, we're just urging. Surely, to goodness, they got enough sense if the federal government is offering money for school mental health counselors.
I'm going to call that comment out of order. Your comment's out of order. I'll let you continue your line of comments, but talking about sense of members is out of order. You recognize Representative Mitchell.
I think I'm talking about the department.
You're no longer recognized. Any other questions for the speaker, for the presenter? Representative Hammer, can you tell me, we're mentioning school mental health professionals. Do you know what the strings attached with that particular program? I think there's 10 different programs that you've mentioned.
Thank you, Mr. Chairman. Yeah, I do not know the various details of the program. Again, all my resolution is a statement of urging, and it was based off of a June 15th letter that the Department of Human Services and Department of Education Secretary submitted. It's really just it's a 5-page letter. Sorry, excuse me, 4-page letter, just overviewing. This is summaries of these. I have not had a chance to review the very detailed technical specs, but again, I did have commitments from both departments that they deferred and willing to look at this in a expeditious manner and fashion.
Thank you. And I will ask as well the timing of an HJR, the projected time frame that we look to be here this week. An HJR of substance such as this has to go through a committee in the House, would similarly have to go through committees in the Senate. There may or may not be time for this to be accomplished. So I just want you to be aware of that situation as you move forward with this piece of legislation.
Thank you.
Chairman Terry, you're recognized.
And to that point, whether it goes through or not, or whether the Senate hears it, or however it goes through, I do recognize that you have brought an issue to us that I think does need further, as you said, looking into. And as chairman, I will write a letter to both these departments to get that information for our committee.
Thank you.
Anyone else have any other burning comments they'd like to make? Question is called. All those in favor of sending HJR 7016 to full health committee, please signify by saying aye. Aye. Any opposed, please say no. The ayes have it. Your bill moves forward. We're now on item number 11 on our calendar, HJR 722 by Representative Hemmer. You're recognized. We have a motion. We have a second. You're recognized for explanation, sir.
Thank you, Chairman and members of the committee. This is a simple resolution about 988 hotline, which came into play last year, I believe, and has grown in popularity for a number of reasons. It's a very good program that has been brought out through the FCC, and all this resolution is doing is the federal SAMHSA, which is the Substance Abuse and Mental Health Services Administration, has just developed a toolkit. So all that is a number of different marketing materials that they have created in order to help promote this new 988 toolkit. I was able to be on a webinar about this summer, learned a lot about it. We've done things in past General Assemblies to help promote that being new. We put it on the back of student ID cards, but being this is so new, they're still trying to get the word out. And so I was able to come out, find this new tool that is being brought about to help in the marketing of it. So they're able to talk with our State Department of Mental Health, and they found it interesting as well and deferred on the legislation.
Thank you for that explanation. Any questions? Dr. Terry, you're recognized.
Thank you, and I apologize for asking all the questions here. But I guess my question is, in your discussion with the department on this, and this was actually something that I considered as a piece of legislation for this, is getting funds to them for advertising to get the word out. How do we go about doing that? And my question actually would be more to the department standpoint on this is the concern was capacity, and we had the previous bill up here, and the capacity issue to handle the number of calls, number of appropriate calls is really what we're looking at. We don't want, if there's 70,000 calls that are out there and only 20,000 really are the ones that we needed. Now all of a sudden you advertise it and we have 150,000 calls and only 30,000 have needed it. I guess that's my question is this something that they're ready for us to get the word out, or is that something that you've had discussions with them about? Or
Representative Hammer?
Thank you, Mr. Chairman. I can't speak to the Department of Administration, but I will say I did talk to the Department of Mental Health earlier this year when I again attended this webinar on it. And to your point, I was looking at ways to further promote it and listening from actually other legislators in other states and the number of different ways they were doing it, whether it was through excise taxes on cell phone, landline bills, or other methods of promotion, and knew those would be costly and needed some further study. So this was one thing that just came out. Again, wanted to kind of pass this along as a best practice from I'm not sure if anybody in the departments here wants to speak on it. I do know from the overage. So for example, the nighttime calls, there's a national or like a backup call center that it goes to. So I'm assuming that any overages that in capacity would go to the same thing. But I'm not an expert on the administration or technical expertise. I just know that's how one thing works with that.
Thank you. Any further questions or comments? Seeing none, are you ready to vote? All those in favor of sending HJR 7022 to full health committee, please signify by saying aye. Any opposed, please say no. The ayes have it. Your bill moves forward.
Thank you, members of the committee.
Thank you.
Always fun.
We are back on item number 5 on our calendars, House Bill 7025. We had rolled until Leader Representative Todd could get into the room, and he is here. Representative Todd, you are recognized. Do we have a motion? We have a motion. We have a second. You're recognized on House Bill 7025.
Thank you, Mr. Chairman, and I appreciate your indulgence while I was in the other committee wrapping up. I thought there'd be a break, and there wasn't. So what my bill does, it expands the current duty to report related to mental health providers that we already have in the law, and expands that to cover more general and broad threats versus the specific threats that are listed in law now. And since Chairman Zachary's bill made it out of this committee already, and it does something similar, mine actually expands a couple of more sections of code, but I don't want to jeopardize the wording in his so we want to look at the final version once his passes, and then bring something back next spring that will address the other couple of sections in code that need to be addressed as well. So I appreciate your indulgence, and I would just request that this be taken off notice.
Thank you. You've heard the request, and I'll give an addendum to that as well. Leader Cochran has a similar bill that Chairman Todd, Chairman Zachary have all been working on together. So we've got three similar pieces of legislation, and it looks like they've decided to allow Chairman Zachary to go forward. The request has been to take House Bill 7025 off notice. Without objection, bill is off notice. Thank you. Ladies and gentlemen, we have disposed of the calendar for today. Does anyone have any questions, comments, anything for the good of the order? Seeing none, we are adjourned, subject to the close of the chair. We're adjourned, subject to the call of the chair.